So as you look at this, they're really moving away from this. Their mindset isn't fee for service like a traditional health system. Their mindset is, how do we keep these people healthy? And we all know that this is the future of medicine. We've known that if we can keep people out of the hospital, that's a much better model. So I guess my question on this, as we sort of compare, maybe not compare and contrast these two models, let's compare and contrast these two models with what's going on in the traditional health system. How are the emergence of these models covering millions of patients going to change traditional healthcare organizations? And what should our traditional healthcare organizations' response be to these kinds of programs, do you think?
So, historically, we've had just an awful model. Our awful model consisted of, patients come into the hospital for appendicitis, and they get a Foley catheter placed, which gives them an infection. We then get to diagnose the infection and get paid for that. Then we get to treat them for it. And if they get really sick, they go to the ICU and get paid for that as well. All stuff we've caused.
Right.
And so I think everybody's in agreement that model has to go away. I think that, again, the devil's in the details on how it's executed. If you think about these primary care setups that you're describing, it has to be under the tent, under the umbrella of a financial model that pencils out. Because there's all kinds of great things we can do, some of which have been proven, others of which have not been proven. There's a lot of kind of back and forth literature on care management, for example.
Right.
And I would say that in order for it to be truly successful, it's got to first start out under a financial model that rewards doing good. In other words, if I have finite resources and I can work on 10 things, I need to pick the 10 things that I know will not only help the patient, but also will pencil out at the end so that this whole process can move forward. So in our system, for example, as we think through how to implement population health, we're carefully identifying areas of opportunity that put us in that frame of reference, where we're doing good for the patient, perhaps decreasing imaging, for example, low back imaging, MRI, for example. But again, you want to do that under a model where it's going to reward that goodness. And I think the danger on a lot of these systems that I'm seeing is that they have a lot of great ideas going in, but at the end of the day, it's got to funnel into making it financially move forward.
And so, going back to that GE example, it pencils out for employers because they're spending $3 billion on healthcare costs.
Well, it only pencils out if all the things they're doing actually do good.
Yeah.
And I think there's a lot of great ideas about sleep and cooking and all kinds of great ideas of what to do. We haven't fully proven each one of them, and that's one of the challenges.
Yeah. So it's evidence-based medicine. Needs also to be applied to these things. It's not just entrepreneurial Silicon Valley types who are coming up with new models and saying, hey, it's not the trial and error that we're used to in Silicon Valley. It needs to be
right.
Supported by rigorous clinical practices is I think what I hear you saying. Is that right? That's
exactly what I'm saying. And without that, it's frankly destined to fail, because you're going to end up spending if you look at your expenses, they're just going to be through the roof. These may not be physicians, but they're not cheap. And, to have them do a bunch of things that ultimately don't decrease the cost of the spend is, really challenging financially.